Thank you so much for joining us. A lot to discuss here, and I have esteemed panelists with me. I want to start with you, Dr. Sharma. My first question to you, you know, in your opinion, how far has the cancer screening advanced since the past few decades? And have we been able to prevent cancer to become malignant at an early stage?
The cancer screening means we are screening a general population which may have or may not have high risk of having a cancer in their lifetime. So the purpose of screening is to detect cancer in asymptomatic patients which do not have any symptoms, which do not have any signs. Signs and symptoms are not there, and we are asymptomatic persons we are checking. So initially we started with doing breast cancer screening and cervical cancer screening. For that we have mammography in breast cancer, and for cervical screening we have pap smear, and we can do now HPV test also. So initially we had pap smear for cervical, and for digital simple mammography was there. Now we have the advancement over last 1 decade. For each and every type of cancer we have advancement in the screening techniques also. Now earlier simple mammography was there. Now we have digital 3D reconstructive computerized mammography which can reconstruct and which can very well the doctor can detect the cancer and can characterize any abnormality very effectively in breast. In the advancement of cervical cancer, we initially had pap smear where we used to see that morphologically the cells type, whether it is having any dysplasia, metaplasia, or type of any at least chance of development of precancerous cells. Now we have the advancement in that finding that if there is any HPV virus positivity, then there is a high risk of chance of developing cancer. So if you consider other cancers also, there has been various advancement in as compared to the last 1 decade, and we can easily detect few at least where we are doing the screening those cancers early to prevent that death from the cancer.
As far as our country is concerned, we definitely, the experts have the knowledge and have the expertise. But how far we have been able to put it into practice, you also know about it, that as for the cervical cancer screening is concerned, only 3% people have been screened so far. Rest is in paper. 97% people are not screened at all. And this is what we find that, the screening is, look at the Western world. They started their journey about 65 years back, and they have made a tremendous difference that, their mortality has come down by 80% and the incidence has come down by almost 70%. And I think, we have started taking a baby steps. Whatever is the reality is right in front of you.
Totally agree, madam. I think moving forward, we should focus more as a public service for screening, and it has to come from the government that we have to push for screening. We as private players can only play a little part, but it has to come as a public service.
Dr. Sharma, do you think increase in awareness aspect of early signs of cancer amongst the oncology fraternity has greatly helped in shaping present screening techniques? And do you have any specific examples on this?
See, in oncology fraternity, we doctors, we are medical oncologists, surgical oncologists, radiation oncologists. They are themselves doing CMEs to update newer techniques among themselves also. Even we are also doing social service where we are doing, educating the people in the societies where they get togethers, and we are doing campings where we do the initial pap smear screening for the people who come for that camps. We are doing free camps, and there we are having a social lecture also to educate the general public for that that we have to do the screening to prevent or to detect the cancer early in those patients who are even asymptomatic. So these type of services and awareness have increased, and I think all doctors who are related with the cancer treatment are doing this service.
I think very technical stuff. Dr. Jain, your thoughts on this?
See, I think, awareness is really needed in public. And I think it is very much possible. Right in front of you is an example of COVID times. The media came so forward that each and every child knew about vaccination, leave aside an adult. So I think, there is less is said about the awareness in public. It can be created. We have the expertise, and the only thing, it has to reach to the people, and then only things are possible. The government of India had made a theoretical plans that, breast screening, cancer cervix screening, and the throat cancer screening has to be done every 5 years, 30 years onwards. But I will say it is still on paper. Still on paper.
Dr. Garg, how do you see this correlation between increase in the awareness and shaping the present screening techniques? How has it panned out in your opinion and helped doctors?
I personally believe that, the doctors were always aware and they were always willing to share the fact that we want to help patients and detect them earlier. What has now happened with the media getting involved, with people, the priorities have changed. Cancer has always taken the back seat because communicable diseases were always on the forte, TB and everything. But now, with the non-communicable diseases coming up, the lifestyle diseases coming up, you have more and more jump in these number of cases, and now patients themselves have started to come and ask us, how can we get ourselves screened? And that is where the major difference is. Doctors have already always known that this is a priority, but we had other things on our mind. But yes, it is catching up definitely.
Dr. Sharma, when you talk of cancer, there are a lot of myths associated, especially related to the screening part of it. There's a lot of hesitancy. Patients are not aware of it. How are you able to clear these for the patients? Give us a sense of that.
Actually, the screening for the cancer means that we are detecting cancer in early stages if there is any cancer in any person. So that first and foremost fear with the persons is that if he is detected with cancer, then he will be blamed and he will be tagged as that. If he is having cancer, then it is a type of death sentence. So people are generally do not want to come forward. Another thing is, if they detect, then they will do the biopsy, they will do further tests, they will subject to another staging test and all that. So people are usually afraid of doing biopsy also, because they may think that if they found the cancer, then it may spread with the doing biopsy. So these are two types of myths. I think people are usually reluctant for this screening.
Dr. Jain, give me some examples of has it happened, and how did you convince the patients, that it's all fine to go for screening, and in fact that is going to help them rather than, they being very concerned about it. And is it still prevalent, despite we advancing so much and so much of literature around, articles around, cancer awareness? Do you think it still persists?
I think what Dr. J.V. Sharma has said, it is 100% correct. First myth in their mind is, I'm asymptomatic. I don't have anything. I don't have anything. So they know it, that I'm okay. Why should get investigations done? The second myth which he has pointed out, that, karayenge to kuch niklega hi. So they don't want to come. And third thing they have in mind, that they can be an overdiagnosis, they can be underdiagnosis, and if they're I will be subjected to investigation, is going to spread. Let me be very frank with you. Slowly, when they're coming repeatedly in our clinics, we definitely emphasize that, look, we have to get this particular screening done for you in 100% of cases. Because now when the WHO says the screening has to be done to the tune of 90%, then it has to be done. And the target which has been even given for cancer cervix and for the breast is that at least 70% should be screened. We are far away from that, the kind of figures which we have that. But, I will say that, we have not been able to break these inhibitions among doctors and nurses widely beside the public. डॉक्टरों को भी बोलो कि आप आओ अपना चेकअप कराओ, वो भी नहीं कराते सर.
Dr. Garg, what is your story been? How have patients reacted to it?
So I feel that the kind of screening that we have in our country is an opportunistic screening. People don't come up by themselves, but if a person in the family gets diagnosed with cancer, then everybody starts fearing it, and then they themselves come up that now that my relative or my cousin has been diagnosed with cancer, how can I now prevent myself? So what Dr. Jain mentioned about COVID, it was the perception of fear which was around everybody, that everybody reacted and wanted to get treated. That perception comes only when somebody close to you gets that cancer, and then only do they start seeking medical help, that how can they avoid it amongst themselves. This is unfortunately not percolated into the general public. What we are doing right now is opportunistic screening. The mother gets cancer, the daughter comes up and says, I am worried. She's not worried for herself. She is worried that her daughter will get cancer. So we tell them that, it's not your daughter. You are the one at risk, and this is where the counseling starts. So this is where we have to catch on these patients. And believe me, my job is to tell public the figures and create fear. There's a difference between fear and panic. Panic should not be there, but the fear should be there. बच्चे फेल होने के डर से ही एग्जाम के लिए पढ़ते हैं, तो आपको ये डर लाना होगा कि आप कैंसर से you can fail from cancer. If you don't have that fear, you will not be able to get them to screen.
Yes, I think one has to be aware. I think not panic. Of course, I think that's a very important point mentioned there. There are a lot of barriers, as you pointed out. People have a certain perception, which is, of course, doctors help them overcome it. But Dr. Sharma, what are the common barriers associated as far as screening of cancer is concerned, from a doctor's perspective? And in your view, have the regulatory bodies helped in mitigating that?
I think we already have discussed the common barriers because the people, if they are asymptomatic, they are not coming forward. Like Dr. Shubham told, that if any person who has a family history of cancer in their family, they will sometimes come forward, or you can explain that this patient, your mother is having a type of genetic disease which is familial, which can pass in the family. So you should be very aware, and you do some test and screening test for them. They are usually coming forward. I think for government point of view, there are no such guidelines for this screening purpose. Screening is available, I think, all the government hospital, but if the people are not coming for screening, then what the government is going to do. And I think government should frame guidelines, like Dr. Jain told, that only 3% of the population is being screened. So what about for 97%? I think it should make either mandatorily for example, like for renewal of your driving license, you have to do this type of test, and then you can get. So some type of mandatory things should come in the force, so that you can do at least this type of screening in that for that has to be purposefully effective.
See, I feel, not only what Dr. Shubham has said, that when the family members has cancer, then you should come forward. That happens. But I think, every visit of a patient for any other reason, we should make it a point that, they must like a woman comes to me, I will definitely screen her for breast cancer as well as for cervical cancer. It is a must as far as I am concerned. But I think similar way, everybody has to be very enthusiastic that every opportunity the patient is there in your clinic, you should make use of every opportunity for this screening thing, and then only things of this kind is possible.
Dr. Garg, your thoughts on this?
So I think one of the very common barrier is the cost and the availability. You know, we are sitting in a metro city, so it's easy for me to talk about getting a CT scan done. But when we talk of a screening and screening program as such at a national level, we have to also look at the availability of the screening test and the cost which is involved. It might be easy to tell somebody in a Delhi that, you know, you need to get a mammography done which costs 2,000 rupees. But to tell a family member whose monthly income is probably 40,000 rupees to get a annual mammography might be difficult. So without you know, putting numbers to it, we need to make it easily available and easily affordable, and we have to somehow rope in the private sector, because government does not have the ability to screen so many people. We have to get this, and the funds are available. It is not. So Ayushman scheme is something which is very useful, and somehow we have to subsidize these screening tests so that all the hospitals which are available in tier 2 cities, tier 1 cities are able to take this up for the patient. So this has to come up.
You know, a lot of people watching us, you know, have this question, you know, this is a very genuine question, and everyone wants to know that what are the risks associated when we go for tests, when patients go for tests, and are there any health hazards of this test over time? Dr. Sharma, starting with you.
Yeah. See, that most important is sometimes we do the overdiagnosis. We suspect and we do the further tests. So this is the hurdle. And other is the radiation exposure. If we do mammography or low dose CT scan, people are afraid of having radiation. But it has been found that that radiation exposure is usually of low doses, and it does more, means more better as compared to the more harm. So the life saved is more as compared to the any harm we get while we do mammography or low dose CT scan. So I think these are the two reasons. One is the radiation exposure. Second is the sometimes overdiagnosis, which may lead to that unnecessary biopsies, and
Right.
sometimes that late diagnosis or diagnosis.
Your thoughts on what are the risks associated with?
Let me be very frank with you. As far as the females are concerned, the priority things which are put for screening are breast cancers as well as cervical cancer. As far as the ovarian cancer and the uterine cancer is concerned, they have not been good cancers for routine screening, because when the incidence of any cancer is less than 5 per lakh, then probably does not call for a screening. That kind of a thing is there. So I find, as far as the breast screening is concerned and the cervical screening is concerned, there is no method which can in any way harm these people. As for the mammography is concerned, I'm sure when the mammography is done, you know, where it is done, they make it very, very clear that there is a referral sheet is there and you are not pregnant at that particular time, then only this particular thing can be done. So I see no reason, you know, there are no screening tests available today that it calls for any kind of health hazards per se from the screening. So I think, you know, this assurance has to come to the public by the senior people like this, and they have to time and again come on the media and, you know, reassure the public, because these programs are listened by many, many people. So I think, you know, something like this, you know, cancer awareness program will come at Doordarshan at 2 o'clock every day. So I think, you know, that is the kind of an awareness is required in this particular country.
Absolutely. I think that's our attempt, you know, at Businessworld as well, you know, that we want to raise this awareness, and that's precisely the motto behind this conversation that we're doing. Dr. Garg, give me, what do you think about these health, concerns that are associated with tests, you know, and are there any hazards in the over the long time?
So, like Dr. Jain mentioned, there are very few hazards associated with these tests, and most of the people come to us and they talk about the radiation that they might get associated with the mammography or a CT chest. Believe me, the radiation that you get for a mammography, equivalent amount of radiation you get in every flight that you take from Delhi to Bangalore. So the amount of radiation that you get exposed in mammography is similar to the amount of radiation you get in a long flight. So it is not that there are no risks, there are some risks, but if you explain it to the patient that those risks are worth the benefit that they might have, they will understand. So if a patient gets diagnosed with a cancer, for every 220 CT scans which are done for lung screening, I will save one life, and that one life will be thankful vis-a-vis that 219. The number for breast cancer is 1400. So 1400 mammograms you do, you will save one life. The point is that they have to understand the risk to benefit ratio. If the benefit is more than the risk, then it is a risk worth taking. This is what we do all our life, and this is what we have to explain to the patient.
Great. Dr. Sharma, what kind of surgical methods are available to ensure that there is correct detection? And of course, through that, a lot of concerns are addressed as well.
Surgical methods, I could not understand your question. Please repeat it.
What kind of surgical methods are available to ensure correct detection?
Any imaging that you do, if you do a mammography, if you do a blood test, if you do a CT scan, they can only point you towards having the risk of having that disease. But doing a biopsy, which I think what Ruhail's question is about, can help you ensure whether this is the right suspicion or not, which is what we call as a biopsy, where in case of an oral malignancy, cancer of the head and neck and the mouth, you can take a small biopsy. Similarly, in the case of cervical cancer, if you feel that there is a lesion present, a gynecologist can very comfortably in their office itself, without any major risk, can take a small punch biopsy. It's an office procedure, completely safe. The patient goes home within 15 minutes, and this has to be told to the patient. Similarly, in case of breast cancer, when there is a suspicion of a breast lump, which is again highlighted on the mammography, it is very easy to do an office procedure where you do a cord needle biopsy and take these out. These are, I will not call them surgeries. These are just small procedures where you can confirm the diagnosis that has arisen because of suspicion that has come out in screening. Because screening, the problem with screening is anxiety. Every lesion that you pick up, you will put a seed of doubt in the patient whether this is cancer or not. So you should also have the next plan ready if you suspect a patient on screening, that you need to do a biopsy for that.
Yes, I think what Dr. Shubham has said, the screening is meant, if you are suspicious about things, it need to be confirmed, and confirmation is always by biopsy.
There are also cases of false positive / negative results, a lot of cases like that. How do you ensure that such issues don't arise? And what methods do you adopt, to ensure we try to mitigate such results?
We find that we suspect any lesion. For example, I'll take the case of breast lesion, which has been detected on mammography. And we have done the FNAC, and the FNAC shows that it is atypical hyperplasia or something like that. So it may be a non-cancer, but patient is likely to have cancer in future. For that, we need to do repeated biopsy at repeated intervals. So first thing, we explain the patient, we counsel the patient, and we reassure the patient that you are not having cancer right now, but you have a lesion which might turn up to a cancer at a later stage. So better if we remove this lesion at this point of time only, so that you are spared of repeated biopsies or repeated examination. One thing that we explain, that if the patient does not agree, we tell that, okay, this may not be cancer right now. We will follow it up after 3 months or maybe after 6 months. We will do repeat mammography, repeat X-ray, and we can do at that time, if it increases, then we can do repeat biopsy also. So first counseling, second patient, whatever is available, if we remove it then and also right now, then we can cure it. And third is, if there is underdiagnosis or sometimes we don't find, then we have to ask the patient that you have to come after 3 months or 6 months.
Dr. Jain, how do you tackle these false positive negative results?
Things are very simple for me. There are 2 tests available. We can categorize all screening tests into 2. One is sensitivity. I have a cancer and this test is positive, which need to be confirmed again. And I do not have a cancer and this test is negative. And this is what is the specificity is very much important. If the cancer is not there and the test is negative, now the public wants to know and reassured by the doctor that, this particular test has got a very high specificity, and that's why you do not have a cancer right away. But at the same time, you must come back for a follow-up on a yearly basis, on a 3-yearly basis, depends upon that. So I see that, whenever there's a suspicion raised, say, I will take an example, which is a very screening positive thing, that's cancer cervix. Now, once we suspect on the cytology or VIA or a Willi, then, that biopsy need to be taken. The biopsy need to be taken under the colposcopy cover, which gives us a magnification of 15 to 20 times. And then you take a biopsy, and if it confirms, then only we go ahead. So I think, no treatment is ever envisaged, whether it is a mammography. Again, when a mammography is suspicious, then when you are taking a core biopsy, if you do it, if you combine with imaging, the accuracy becomes very, very easy. So I think, now the ways and means are done that when the screening is positive and you are trying to confirm it, you use extra gadgetry. So the chances of missing that particular disease is not there. So I think, things have become very precise, and all cancer specialists and ordinary doctors know about these things, and the public can be easily told about the same.
Dr. Garg, your thoughts on this?
What Dr. Jain mentioned were the statistics, sensitivity and positivity. For me, false positives are still okay. Believe me, you have to make a patient understand that these are screening tests. We are not telling them that you have cancer. We're just telling them you have the doubt of having cancer. And if that screening test tells me that you have suspicion, I will do a confirmatory test. I am not going to operate you or give you chemotherapy on the basis of this test. I will do another test on the basis of this test, which will confirm whether you have cancer or not. And this is what biopsy is, what we were talking about. The problem is with false negatives. False positives are still okay. False positive means that the patient does not have cancer and was suspected to have cancer. This is false positive. He or she will get a confirmatory test which will confirm whether she did not have cancer. The problem is with false negatives. False negatives gives you the false assurance that you did not have cancer, and for the next 3 months or 6 months or 1 year, you will not get any other test done. So that is why it is very important that you should not just blindly have a screening test. You should also combine it with consultation with a clinician, whether it's a gynecologist or an oncologist or whichever physician, so that they can corroborate that test and ensure that the false negativity at least comes down.
We have a lot of questions and a lot of questions coming as well, but I think this is going to be my final question because we just have, say, around 4 to 5 minutes left. Dr. Sharma, quickly, do you think genetics play an integral role in diagnosis? What do you think is the ratio of cancer diagnosis of people having cancer, heredity, and first-timers?
Generally, if you see, I'll take the example of breast cancer. In breast cancer, approximately 5 to 8% of the cancers are hereditary. Means this may be related to that there are 2 genes, BRCA1 genes and BRCA2 genes. So if the mutation in this, either of this gene, if there is mutation that is carried forward to the next generation, so these are germline mutations which are transferred to the progeny, and if the genes is present in that family, they are likely to have the breast cancer, chance of developing breast cancers are like 100% in their lifetime. Other cancers are also associated with the BRCA1 or BRCA2 gene mutations, like the cancers in male breast are also associated with this. Ovarian cancer, pancreatic cancer, in male prostate cancer, colorectal cancer. These are the cancers which have high chance of developing in these patients who have a genetic mutation, BRCA1 and BRCA2 mutations. So this is very important to know the genetic profile of a patient who is having a cancer, so that you can advise or counsel that rest of the family that you have to be aware of the fact that your mother or your father was having this type of cancer with this genetic mutation, which is likely to be forwarded to the progeny, your brother, sister, and other family members also. So you have to be careful, and you have to get screening for such type of cancers, and you should not delay any symptoms or signs related to this.
I think the genetics, as Dr. Sharma mentioned about BRCA1 and BRCA2, it has got a lot of significance because it has been seen that once these genetic mutations are positive, there is a significant increase in the breast and in ovarian cancer. So I find, these screenings, previously they were very expensive, but they're not very expensive now at all. And especially people with their family history should definitely get them screening done. And in case if the screen is positive, they should take the corrective measures there. Especially so in cases of ovarian cancer, if there's a family history, then we know it if BRCA1 is positive, and ovarian cancer, all mortality because of ovarian cancer is on one side, and the other mortality by rest of the cancer is on the other side. So I think, if we come to know if BRCA1 is positive, and the chances of ovarian malignancy increases anything between 30 to 60 times. And in case if BRCA2 is positive after 70 years, the risk increases from 1% to something like 20%. I think it is significant. But I think, still in medical fraternity also, this awareness is not there. And even if the awareness is there, they don't wish to get it done. So I think, some barriers has to be broken as far as this thing is concerned. And I think, as Sir has pointed out, that now the genetics in relations to cancer is picking up. And I think we should be creating more doctors' awareness first, and through them, we expect public awareness.
One more thing I want to add, that those people who have BRCA1 and BRCA2 mutations, cancers in there is in early ages, for example, 20 to 30 years. Otherwise, the chances of cancer development based on the age is around 50 to 60 years. But those persons who have this type of mutation, BRCA1, they are likely to have cancer at a younger age. For example, 20 to 30 years of the age.
So I've heard what Dr. Jain and Dr. Sharma mentioned about genetic thing, but this is for the general public, not for the doctors, that, it does not mean that, if somebody had some cancer in your family and you will get any genetic test done for you. There are specific tests for specific organs. We are aware as clinicians that there are many tests there in the market which says that you get this blood test done and we will tell you the risk of you having cancer, which is wrong. So it should not come out that, if you have any family history, you need to get genetic testing. For example, if somebody in your family had a tobacco related head and neck cancer, you are not at risk of having, because that is not genetically hereditary. So that is why inherited. So we need to really counsel these patients and then weigh in getting the right test done, because believe me, these are double-edged swords. The day these genetic tests lose their credibility because you're getting them done too much and they are not giving you results, even the patients who really deserve them will not be able to get them, or they will get prohibitively expensive. So I feel they should be done judiciously and not everybody should get them.
Thank you so much. Wonderful conversation, so much to learn from our esteemed speakers and experts. But we're out of time. We hope we will continue this series, and thanks for joining us and sharing your thoughts on this.